Thank you, AOS and Dr. Khungar, for giving me this opportunity. I'll be talking about phacoemulsification in high myopic eyes. Now, basically, we need to understand is that in the current scenario, myopic patients and myopic cataract surgery is increasing. And our emphasis on this topic is because myopia, a myopic eye is not just a long eye, it's a biomechanically unstable eye. So, as we commonly encounter cases where the axial length is greater than 26 millimeters, or extreme myopia where the axial length is more than 30 millimeters. And we all know the altered biomechanics, like the large bag, the incidence of posterior cephaloma, weak zonules, liquefied vitreous. All these are add-on part of our surgery which we need to take care of. Obviously, we need to have a thorough examination of the retina by our retinal colleague, and only then that green flag when it is given, we can go ahead with the surgery. Now, optical biometry, though, is the gold standard. One should repeat it, preferably with another optical biometer, or if you have the swept source technology, then optical biometer of that quality is a must. Modern IOL formulas like Barrett Universal 2 are the ones which give you better accuracy. The modern formulas for myopia will give you an accuracy in the range of 0.3 millimeters, 0.3 diopters. So they should be used rather than the older formula. Obviously, OCT is a must for all case, especially the macula, and a peripheral retinal screening. Here, this is the fundus photo showing a lot of changes, as we all know, that are common with myopics. A B scan should also be done so that you might discover a cephaloma which was missed otherwise. OCT, as I just said, is important. The RNFL also is bizarre in myopics. It doesn't follow the characteristic hump pattern because of the thinning of the RNFL. But it's stable, so it's not basically, it can be differentiated from glaucoma. Here, what I need to emphasize is this is a case. A young lady having an axial length of about 29.6 millimeters. And here I have put two different biometries side by side to emphasize that though SRKT is accurate, you need to have the Barrett Universal 2. So here the power was coming with Barrett's U2 minus 2.18. And that was pretty accurate when I went ahead with the surgery of this case. Also, there are other formulae like the Kane, the Olsen, which take into consideration that the ratio of the posterior segment of the eye is altered. So you have a larger vitreous cavity, and that too has a liquefied vitreous. So the refractive indices change, and these formula take that into consideration. But for the general ophthalmologist, always target myopia, maybe minus 0.5 or 1, and definitely beware of a hyperopic surprise. Obviously, because of the deep anterior chamber, the ELP may be different. So negative power IOL planning also needs to be done. Now, once you start the surgery, which I'll just elaborate, the deep chamber is a challenge. There is posterior capsular trampolining, that's the lidris thing. And I'll just demonstrate on the video where it's pretty evident. Also, the reverse pupillary block and the zonular laxity. Now, we all need to know that our surgical parameters for high myopes need to be different. So, the rhexis, because the things appear to be closer to you when you're doing your surgery. So, you might end up with a rhexis which is larger than what you anticipated or what you desired. So, rhexis should be spot on. Your gentle hydrodissection, your settings should be adequate for high myopes. So I'm using an IOP of 36, a vacuum out here it's more, but generally 300 to 400, and an AFR of about 25 to 30. Definitely a vertical chop works better because of the deep anterior chamber. The fluid expulse, as we all know, the IOP or the bottle height should be lowered. A very stable wound construction is a must here. See, if your wound is slightly leaky, the fluctuations which are already going on will be accentuated. Number two, if you have a long tunnel, number one, you will have overlocking and the stress on the cornea because your direction is towards the vitreous of the phaco handpiece. So you're going to have more striae on the cornea, so your visibility will be compromised. Obviously, the IOL of choice in such high myopes is a multi-piece lens because it fits into the bag very well, but you can have other options as you desire. The multi-piece lens has another feature, it has a very sharp optic edge, and that prevents PCO formation. And we all know that YAG in such cases may contribute to a retinal detachment. So RD risk is definitely higher, it's higher in younger patients with high myopia. You need to counsel the patient regarding that, and obviously urgent referral in case it does occur. So these are just the summary of that. If we take the take-home pearls, number one is the formula optimization, and that is very important. Control of the fluidics, again, is of paramount importance, and you should have, number one, a pre-op retinal examination by your retina colleague, and also a retina person who will manage these cases, see these cases, let's say 4 to 6 weeks after surgery. So I'll just go on with my video. So as I said, the red glow is excellent in high myopes, but your rhexis tends to be larger than what you had aimed for. So the movement of the viscoelastic should be heavy. I prefer 1.4% sodium hyaluronate, and the movement should be towards the roof of the cornea so that you achieve 5 to 5.25 millimeter rhexis. Hydro procedure should be gentle because you know that the anterior chamber may fluctuate, and in these cases, later on you have a harder nucleus, but generally they present to you earlier. Phaco settings, just as I pointed out, the IOP should be low, AFR should be on the lower side, and the vacuum should not exceed 400 millimeters of mercury. So here again, the protocol is do slow motion phaco, do it very gently, and never allow, now you can see the fluctuations, and that lid risk also occurs because of that, where you can slightly nudge the iris and prevent it. Aspiration irrigation, I prefer the bimanual approach. This is my own device, Bhargava hydro implantation irrigator, which has a flow directed posteriorly. So it maintains the anterior chamber much better than the conventional irrigator, which has a bidirectional flow. Meticulous cortical cleanup is necessary, and each fiber needs to be removed because you have to reduce the incidence of PCO in such cases. Here, my preference is a multi-piece lens, and as I just said, the cartridge has to be specific. You can use a B cartridge, which is a larger one, but I prefer the C one, and my incision size is 2.8 millimeters. We are all used to implanting single-piece lenses and rather one-piece lenses. Here, the configuration of the haptics is a little intimidating. So the basic rule that I follow is, first supinate your hand while you are inserting the lens, and once the optic is in, then pronate it so that the orientation of the haptics comes out very predictably. Secondly, dialing such cases is a little difficult because of these memory-oriented haptics. So better nudge the IOL into the capsular bag. So as you can see, the rhexis is well covering the IOL, and then I prefer the 3 and 9 o'clock position so that photopsias are minimized. Remove every morsel of viscoelastic because viscoelastic behind the lens might contribute to PCO and also a refractive surprise. So my take-home message, my experience, it basically boils down to three things. In high myopic cataract surgery, if we remember three things, we can have great results. Number one, plan carefully. Number two, control the fluidics. And number three, respect the retina. Thank you for your kind attention.
Any questions for Dr. Bhargava?
Beautiful technique, beautiful surgery on that.
Thank you.
When you have very myopic eyes, do you have a preference if you're going to do a primary piggyback IOL?
Okay, that depends on what the power you've calculated. Like this was the IOL power was -3, so it's available with Alcon. I think they go down to -6. I haven't operated any eye which had a power more than that, but definitely, like you say, a piggyback can be done if the eye. It's more common in hypermetropes, the piggyback thing, but in myopes, I have not done it. But yes, you have a valid point. Thank you.
I think piggyback is much easier and much safer in myopic eyes because you have a larger AC depth. So you can plan that.
Absolutely.
And about this three-piece Alcon you had to put because of the power. Rayner has hydrophobic IOLs which go up to -8 diopters.
Okay.
Those are one-piece IOLs. So that you can plan in case you don't want three-piece IOLs. So we can.
I think
take
Alcon goes
Alcon.
up to -6, so
Alcon
that
so
is
only it is Rayner in the market which gives us hydrophobic IOLs which are up to -8 diopters. They are preloaded lenses, so we usually
And
use
in
that.
addition, I'd like to add, there's an Indian company, IOC, which can customize your lenses. Suppose you want you are operating a high myope where a toric lens is not available. So you can send them the parameters, they'll design that lens and send it to you so that you can have a better refractive outcome. Yeah. Correct. That is the reason why we don't have single piece lenses for these high numbers. But yes, if you feel that there is a zonular laxity, if you feel that the bag is a little more floppy, then I think a CTR would be a very good option to support your IOL, as well as, I don't know of the PCO rate incidence, how does it go down or not, but yes, it's definitely a beautiful option.
Uh, Anything about LIDRS you'd like to add, that how to tackle LIDRS?
Yeah.
One is that reverse.
That is, yes, absolutely, absolutely. That is such a common entity, your lens iris diaphragm retropulsion syndrome. Now, first thing that you will do is your IOP settings. You're going to have a low IOP. You're going to have a low AFR. If your AFR is less, the fluctuations will be less. Third is your incision, like I pointed out, it should be adequate. And if it's occurring, then what you can do, you can take a spatula and just go beneath the iris and just tent it upwards. So then the pressure normalizes and you can continue with your surgery.
We have an ongoing study at our center in which we are using replenishing the intracameral lignocaine again and again in these cases, and we have seen that the amount of IRDS is slightly LIDRS is slightly lower, and in fact in many cases not there.
Okay.
The hypothesis that we thought of after reading the literature is that these eyes usually have a lax, the eyes which go into LIDRS, they have lax zonules. Now what happens is when we enter, there is a, because in myopes there is a sudden deepening of the anterior chamber, there is more pain on the zonules, there is stretching on the zonules, and that causes further ciliary body contraction. So if directly injecting lignocaine and again on the ciliary muscles, that will not cause their contraction. So only thing we are left out with the lax zonules. So that decreases the incidence of LIDRS.
That's a great point, and that just goes to say that LIDRS is not only mechanical. It is
So
chemical also.
this paper we had presented in ASCRS last year. Any other questions? So if we don't have any